Hi, welcome to the first in your series of presentations, Cracking the Code, an introduction to CPT evaluation and management coding. I'm Dr. Julie Pennick, one of the faculty in the online nursing department. So what is the CPT code and why do you need it? CPT stands for Current Procedural Terminology. So it's a standardized classification of codes that link to services provided, procedures performed, tests performed, treatments performed when you engage with these activities with your patient. You will include CPT codes for your evaluation and management services, which is the focus of this presentation today, as well as any tests or procedures that you engage with your patient during their visit with you. So here you see represented categories of CPT codes. So we talked about evaluation and management services, and we'll talk more in depth about those codes momentarily. Any pathology and laboratory procedures, there's a range of codes for those, radiology procedures, surgical procedures. This slide just provides you a broad overview of those numbering systems. As I said, the focus of today's presentation is on evaluation and management codes. This is the only CPT code that's required for you to select at every visit that you have with your patient. It is key because it allows for appropriate reimbursement based on appropriate billing for the services that you provide. And each individual practitioner is held accountable for the accuracy of the code that is selected, even though practices employ billing and coding specialists. Know that it's the individual provider whose name is associated with those services and the codes utilized that will be accountable should an audit turn up that there was inappropriate application of a code. In this cartoon, you'll see these two gentlemen are staring at what appears to be this abstract art, and it says it's called Path to Payment. It used to be a very convoluted process. With the 2021 updates, it will be a little more straightforward. Selection of your CPT code is based on patient type and the setting. A new patient is one who has not been in your office for the last 3 years. Let's say the patient is known to you but hasn't been in the office for an encounter with you in 5 years. The patient is technically reestablishing, but for coding purposes, you may utilize the new patient codes. An established patient is any patient who's been in your practice within the last 3 years. Settings that you will likely be involved with in your role as a nurse practitioner include clinic or outpatient, telehealth, hospital, nursing facilities, or home care. For your outpatient services in your office, these are the codes that you will utilize most often. 99201 was rarely used for a new patient encounter and in fact has been eliminated in 2021. New patient codes now go from 99202 to 99205, and established patients CPT codes encompass 99211 through 99215. There are different codes for preventive health services, new patients, and these, as you will notice, are based on the age of the individual being seen for the preventive health services. Logically, just as there are preventive health exam codes for your new patients, there are special codes for your established patients. They are based on the same age ranges as the new patient preventive health codes are. Telehealth visits. The codes have been in existence for a while, but we really saw a huge upswing in utilization of these codes with the COVID-19 pandemic disruptions that occurred, particularly in early to late 2020. There are 3 telehealth visit codes: 99421 for an interaction of 5 to 10 minutes, 99422 for an interaction 11 to 20 minutes, and 99423 for 21 minutes contact or more. And as you can see, the reimbursement amounts are included on this slide. These codes can be used when the patient has not been seen in the past 7 days and will not be seen in the next 7 days in person. You are to document telehealth visits just in the same fashion that you would any other encounter with a patient if the patient had been in the office, and the patients could be required to submit the copayment for this service. As telehealth services increased in 2020, due in part to the pandemic disruptions of the traditional ways in which we would conduct follow-up and engage with our patients, so must our understanding of the way that we can utilize the telehealth codes. Here are the parameters by which you can utilize the 99421, 22, and 23 codes. There will be services, I suspect, that will continue to be managed in a telehealth fashion, because one of the things that we've learned is that there are certainly services that are perfectly suited and appropriate for telehealth follow-up that we previously had done face-to-face. And we have discovered, and we've always known, that some aspects of telemedicine or telehealth visits increase accessibility of services to many of our vulnerable populations. Starting in January 2021, providers now have the choice. They can code based on the time spent in the patient encounter, or they can continue to use elements of the medical decision-making model that was in place prior to 2021. Here you see the times associated with the codes for both new and established patients. So when you're coding for time, these are all the activities that are included in the amount of time that you can utilize when considering which one of the CPT codes you will select. So it's preparing for the visit, obtaining the history, performing your examination, your patient education and counseling, or to the family members. Anytime it takes you to order tests, send off your prescriptions, perform any procedures, making referrals, documenting in the EHR or the paper chart can be included. Your interpretation of results, communicating those with the patient and or the patient's family, and any care coordination activities. That's a lot of things that can be included in the time. So here's what that looks like. So for a new patient visit, you see we have the 99201 for 2021 no longer applicable. The reimbursement is the same in 2021 for a 99202, 203, and 204, which is why it becomes a very straightforward proposition for the provider to select the code based on time. You can see higher level of reimbursement does come at a 99205, and those are the encounters that represent higher risk and higher medical complexity when it comes to your decision making, and you may want to do your due diligence in providing documentation to support assigning a 99205. Here's for established patients. Again, the reimbursement is the same for 99212, 213, and 214. Again, there is a greater level of reimbursement for a 99215. Hence the reason it might be of greater value to go through the steps with the medical decision-making process to be able to substantiate selection and assigning of a higher level of a CPT code, the highest level of a 99205 or a 99215. It's a difference between $60 to $80 reimbursement per visit. Well, let's talk a little bit about add-on codes. So we talked about the base CPT evaluation and management codes. Prior to 2021, there were codes 99354 and 99355. Those were codes that providers were able to utilize for prolonged services. Mentioned in the information and the overview relative to the changes for 2021 is the GPC1X code for primary care providers and the GCGOX code for specialty providers. It is unclear by many of the authors that I reviewed exactly how these codes will be utilized. It is also unclear if they will completely replace 99354 and 99355. Probably as the new coding guidelines unfold in 2021, we will all gain greater clarity exactly to what is the best way to utilize the new codes and if utilization of the former prolonged service codes will even be applicable. Let's talk about documentation and support of the level of evaluation management code that is selected. Prior to the new guidelines coming into play in 2021, providers had to document in the subjective data set. The more they documented, the higher level of CPT code they could select. For example, if they wanted to select an expanded problem focus, which was a 99213 and perhaps even a detailed a 99214, the provider would have to have at least greater than or equal to 4 elements represented in their HPI. In their review of systems, they had to encompass a minimum of 2 to 9 systems. And in their objective data set, when doing their physical exam, if they wanted to code higher than a problem focused, if they wanted to do an expanded, they would have to do 6 elements or 6 aspects, or as they referred to in the guidelines, 6 bulleted items in a single system. But if they wanted to do a detailed, they would have to do 2 bulleted elements in at least 6 systems, or a total of 12 bulleted elements in 2 systems. So it was a lot for the provider to have to take into account. Now, also take into consideration that as we move to the 2021 guidelines, the electronic health records that are used are based on guidelines prior to 2021. So those templates are driven to drive providers to collect more information in the subjective and objective data set. Software engineers are going to have to engage with providers to look at the need for revisions to the electronic health record platforms. Thankfully, in 2021 guidelines simply say that for outpatient services, the provider collects a medically appropriate history and physical examination, appropriate to the chief complaint that the patient presents with. This is a tremendous savings in time and is of tremendous value to the provider. Should the patient's level of medical decision making prove to be a complex proposition and the provider want to utilize medical decision making in support of selecting a 99205 or 99215, and remember, the other 3 codes, 0212, 0313, and 04 and 14 are all reimbursed at the same rate. So it's really just about using medical decision making, and that complexities are represented when you want to select a 99205 or a 99215. This is how you would do that. The categories under medical decision making include diagnoses and management options, amount and complexity of the data that is reviewed during the encounter, and the risk of complications, morbidity, or mortality. In this cartoon, you see the crystal ball, and Madame Zorba says she will fill you in with the projected cost and other details about your treatment. It was almost like providers needed a crystal ball to be able to determine how payment strategies were going to be utilized. So here's the overview of the number of diagnoses and management options. You literally should keep a little crib sheet. And so if the patient comes in with an established problem, it's stable or improved, 1 point's assigned to that. But let's say the patient comes in, they have a new problem, and you need to work that up. 4 points are assigned to that. Keep that in mind. So now we've got our crib sheet, we've got 4 points. The second element of medical decision making is the amount and the complexity of the data reviewed. Again, have your crib sheet handy. If you're going to review or order labs, you get to take credit for a point. If you're going to discuss a test with the performing provider, you're going to be able to take credit for a point. If you make a decision to obtain all records, you're going to be able to take credit for a point. The third element of medical decision making is determining the risk of complications, morbidity, or mortality for your patient. I'm not going to belabor you by reading the elements in this table, but the table provides you with examples for you to evaluate what is going on with your patient. Where does your patient fit into the risk level of minimal, low, moderate, or high? Utilize those examples for each of the individual levels of risk to help you determine where your patient falls. So now you've completed all three aspects of your medical decision making. You have all of your scores calculated on your crib sheet, and now you're going to plug that into your decision making process as to what level of medical decision making your encounter with the patient achieved. Let's say under diagnoses and management, your score was a 4 or higher, right? Under amount and complexity of data reviewed, your score was a 3. And let's say under risk of significant complications, morbidity, and mortality, you come up with high. So now you have the first category as high, the second category as moderate, and the third category as high complexity. You see down here it says 2 of 3 required. So because you have 2 of the 3 elements that scored in the high complexity, you can code that visit as a high complexity visit. Conversely, let's say under diagnoses, management, and options, your score was a 3. Under amount and complexity of data reviewed, your score was a 3. And under risk of significant complications, morbidity, and mortality, your score was high. You would then code this visit as moderate complexity because 2 of those 3 elements are in the moderate complexity. And keep in mind, since under Medicare reimbursement is the same for a 99212, 213, and 214, the primary reason for going to medical decision making is if you believe that your visit and the activities that you engage with will support through your medical decision making process the ability to assign a high complexity CPT code of 99205 or 99215. That's why you would go through this. Additionally, remember we said the majority of what we talk about here is the Medicare structure for things. There may be different levels of reimbursement for 99212, 213, 214, or new patient 202, 203, 204. There may be greater diversity in the reimbursements of those levels of care by third-party payers, not Medicare. But as I said, the majority of what third-party payers will do will align fairly well with the determinations that the Medicare reimbursement structure is set at. Here's the recap. Evaluation and management level of service billing is based on the setting that you provide the service in, the type of patient you provided the service to, and you determine whether you're going to utilize time or medical decision making when selecting the level. As we said, CPT codes also are applicable for procedures, treatments, tests, and things of that nature, but the focus of this Cracking the Code presentation today was on evaluation and management. Next week, you'll be introduced to another coding concept, the ICD-10 coding system. In this cartoon, as an introduction, the gentleman is hooked up to what looks like a lie detector machine, and the person administering the test says, "Nope, I'm sorry, ICD-10 is not the robot in the Star Wars movies." Bill is trying to fake his way through an ICD-10 test. ICD-10 coding is also a complex concept, and we hope that our Cracking the Code series will help get you through and provide you with a firm foundation of understanding as you approach these concepts in your clinical experiences. Here are some of the resources that I engaged with as I grew in my knowledge to prepare this presentation for you today. Thank you.